Hello friends, I am presenting advancements in the management of endometriosis. I am Dr. Ravikant bringing you greetings from KVG Medical College, Sulya and Endoscopy Committee, Kasoga. I am going to discuss under these headlines endometriosis like tissue which is present outside the uterus behaves completely different than endometrium of the normal uterine cavity. Mainly, there are three types: peritoneal, deep infiltrating endometriosis, and ovarian endometriosis. And in generally, there are 1 to 6% of general population are suffering from endometriosis. But among those patients who are having a chronic pelvic pain, will be having a 50 to 60%. And those patients among infertility, nearly 20 to 30% patients will have endometriosis. The risk factors for endometriosis are mainly early menarche, short menstrual cycles, or obstruction to the menstrual flow, which all will lead to retrograde menstruation or exposure of menstrual blood into the peritoneum for long duration of time. Multiple births, especially, is very good protective factors. Maybe because of the continued presence of progesterone during pregnancy and deficiency of estrogen during lactation period is protective. There is a inverse relation between the smoking and endometriosis. Many patients, those who are smoking, are having less chances of having endometriosis. And there is a clear evidence of association between endometrioid and the clear cell carcinoma of the ovary. Pathogenesis mainly widely accepted is retrograde menstruation, which explains the pelvic endometriosis. Coelomic metaplasia explains the endometriosis in the distal organs like thigh endometriosis, knee endometriosis, thumb endometriosis, even endometriosis among adolescent girls. Ectopic and utopic endometrium behave completely different. Even lymphatic and vascular endometriosis can explain the distant organ endometriosis in the lungs, diaphragm, even the brain. Direct implantation explains the endometriosis of the scar site, maybe umbilicus, maybe in the cervix, or maybe in the vagina, or in the episiotomy site, or previous cesarean section site. There is a one more new theory which explains the endometriosis is by bone marrow derived stem cells, which are totipotential cells which can able to differentiate into any form of cells. So when they are stimulated by particular growth factors, they can turn into endometriotic glands also. Immunobiology. In these patients, the immunity is behaving completely different. Mainly natural killer cells, mast cells. Normally, they should get rid of the disease. But in these patients, it is protecting, sometimes even promoting the growth of the endometriotic glands in a genetically predisposed individuals. There is a hypersensitivity to inflammation in these individuals. Genetics, they have shown that in the first degree relatives are having 6 to 7 times more chances of having endometriosis when compared to those who are not having a family history of endometriosis. Other than endometriosis, these patients are also differently susceptible for implantation failure, infertility, and progesterone resistance. The genetics mainly polygenic, but one gene, that is KRAS gene, which is a trans-regulator gene, which is mutated. So there will be uncontrolled proliferation of cells, and there is a arrest of apoptosis. So these cells will grow uncontrolled like a cancer patients. Molecular mechanism of endometriosis, mainly they produce very high amount of estrogen when compared to endometriosis of the normal uterine cavity, and they are resistant to apoptosis, and there is a very high level of production of the prostaglandins, and these are resistant to progesterone when compared to the endometrium of the normal uterine cavity. The cause of pain of endometriosis may be because of the focal bleeding, which contains inflammatory mediators like interleukins, cytokines, and prostaglandins, and various other inflammatory mediators may be there. And deep infiltrating endometriosis becomes because of the infiltration of the nerves. Whenever there is a deep infiltrating endometriosis, then the pain becomes localized. Otherwise, it could be diffuse pain. The mechanism of infertility is distorted anatomy, kinking of the fallopian tube, occlusion of the fimbria may be the reason for infertility, or inflammation will affect the implantation. There can be aberrant gene expression in the gamete because of the all the irritant that are present in the pelvis. All these are the mechanism of infertility. The diagnosis is delayed nearly by 6.7 years on an average. It produces all types of pain: dysmenorrhea, non menstrual pelvic pain, dyspareunia, dyschezia, cyclic bowel or bladder symptoms. Then, as widely known, infertility. The one special symptom which should be kept in our mind is because of the inflammatory mediators, they can produce just the chronic fatigue. So, in these patients also endometriosis should be kept in our mind. Physical signs, if there is a surface involvement is there, blue colored implants in the rectovaginal septum over the cervix or a site of scar endometriosis can be there. Rectovaginal septum endometriosis will show nodularity, tenderness of the rectovaginal septum. Retroverted and fixed uterus could be because of the endometriosis. Adnexal mass are immobile, they are tender. Uterosacral ligament is be indurated and nodular. CA125, which is widely being used for the diagnosis of endometriosis, which has got a lot of overlap in the normal individuals also, pancreatitis, hepatitis, smokers, and many epithelial ovarian tumors also produces CA125. It has shown that only 20% of stage 1 and stage 2 endometriosis are having a raised level of CA125, and only 30 to 40% of stage 3 and stage 4 endometriosis. The importance of CA125 is its specificity. Means if it is normal, 90% of the cases it is unlikely of endometriosis. One more test that is showing some promising results, which is under development, is microRNA, which is expressed in the plasma of those patients, those are having a endometriosis, but it is still under research. Transvaginal ultrasonography is the best way to diagnose endometriosis because it is located at the site of the lesion and it is real time. It can show hypoechoic area covered by surrounded by hyperechoic area and areas of vascularity. There can be nodular lesions, there can be fluid levels. So all these are the signs of endometriosis. Even rectovaginal endometric nodules also can be seen better by transvaginal ultrasonography when compared to a transabdominal ultrasonography. Whenever you want to diagnose the whole lesions of the pelvis, means you don't want to miss any of the lesions, then we can use MRI. In the MRI, there can be T2 attenuated images which shows where even the smallest of the lesions can be identified by doing a MRI, especially whenever you want to diagnose a deep infiltrating endometriosis, then we can better to go for MRI. So there is a gradual shift towards the diagnosis of endometriosis by clinical basis and a non-invasive test like ultrasonography and MRI. Surgery should not be a means to diagnose endometriosis. Surgery should be done only to therapeutic reasons. So surgical diagnosis is laparoscopy is gold standard. In the laparoscopy, we can see blue, black powder burn or red or flame like or vesicular lesions. These are reactive lesions, they are vascular lesions. If you see white and opaque lesions, they are fibros- fibrosis and old lesions. There can be ovarian or extra ovarian endometrioma, and there can be deep infiltrating endometriosis in the retroperitoneal area. Whenever we do laparoscopy, we should be able to stage the endometriosis. There are two things should be considered. One is adhesions and other is endometrioma. Whether they are superficial or deep, whether the adhesions are filmy or dense. And also one more thing we should consider is the pouch of Douglas, if it is partially or completely obliterated. For each lesions, they can be identified whether they are less than 1 centimeter, 1 to 3 centimeter or more than 3 centimeter, and they can be given the score. Or there can be pictorial demonstration can be done by A represents a rectovaginal septum endometriosis, B represents a uterosacral transcervical ligament or peritoneal endometriosis, whereas C represents a rectum endometriosis. Again, they can be staged 1, 2, 3 based on the size of the lesion, less than 1 centimeter, 1 to 3 centimeter, more than 3 centimeter. Now we can also use focal endometriosis for adenomyosis FA, bladder FB, ureteric involvement FU, and intestinal involvement FI, and other lesions like lung, diaphragm, inguinal lesions for FO. Then we can estimate the least function due to endometriosis on the right side and the left side. Ovary, fimbria and fallopian tube, which is having a good function, score is given 4. If it is having a poor function, we can give a 0 score. The least function of the left, least function of the right is summated. Now we will get a least function score. This can be plotted on the endometriosis fertility index. Age less than 35 years, 35 to 39 years, or more than 40 years. Duration of infertility less than 3 years, more than 3 years. Prior pregnancy, if it is present, it is 1. If there is no prior pregnancy, 0 score is given. Least function score from the previous chart can be added here, and which will give the points. And American Fertility Society endometriosis score can be added in the second, and it will give the points. And the total score can be added, which also will give the points. All put together, history wise and surgical wise, we will get the endometriosis fertility index score. This score can be seen on the prognostic table. Suppose the score is 0 to 3, the chances of having a pregnancy in 3 years, that is during 36 months, is only 10%. If the score is 4 or 5, the chances of pregnancy may be 40% or 50%. If the points is 9 or 10, then the chances of pregnancy will be 7 to 80%. So staging the endometriosis will helpful to give a prognostic value